I have brought a case, and I think it's a really nice demonstration of the usefulness of the L6. This is a patient who has ischemic rest pain of the right lower extremity. Preoperative workup demonstrated a narrow distal aorta. Essentially, the aorta tapers and becomes much more narrow. The left common iliac artery is patent but stenotic at its ostium. The right common iliac artery is patent at its ostium, leaving a little nubbin of patent vessel, and then it's essentially occluded all the way through the common iliac bifurcation, and there's reconstitution of flow through the external iliac artery as a result of internal iliac artery collaterals. This patient has some unique features that could make the case dangerous, but she is a good candidate for intervention and certainly has anatomic features that were worthwhile for use with stents rather than with aortobifemoral bypass or surgical bypass. She was brought to the hybrid operating room. You can see the pre-procedural angio there on the left, basically the anatomy that I simply just described. About 100% right common iliac artery stenosis, about 80% left common iliac artery stenosis. On the right, there's concentric heavy calcification, and on the left is, again, eccentric heavy calcification. I obtained wire access bilaterally and upsized 8-inch teeth bilaterally. Luckily, I was able to cross the diseased right common iliac artery that was actually occluded in a retrograde fashion, and that can be difficult. And sometimes I do go up and over to cannulate these lesions, and then I exchanged my wire out to 018. I unfortunately could not pass the 018 IVUS catheter for sizing, as I always do, and I certainly knew that meant that I would also not really be able to pass my L6 balloon, which is just a little bit, which has a slightly higher profile than a plain old balloon. And so I ended up pre-dilating my right common iliac artery with a 4x60 balloon, which in this case was a Mustang. I'd actually switched my wire back to 035 in case there was any sort of vessel injury. After that was done, I advanced my IVUS, and I confirmed my measurements, and they were as expected based on the pre-procedural CT scan. I used kissing intravascular lithotripsy catheters, the L6, that were used in both iliacs. After having pre-dilated on the right, the L6 flew right through, and I had no problem whatsoever tracking the balloons into the disease. On the right, intravascular lithotripsy was done in two intervals, one at 2 atmospheres and one at 4 atmospheres. And after that was done, intravascular lithotripsy demonstrated really no residual stenosis on the right common iliac and a little bit of residual stenosis on the left. Given that this was a CTO, expected patency would not be particularly high without placement of additional stent or device, and so I elected to proceed with stenting at this level. Based on the fact that she had a narrow distal aorta, I placed an 8L, I placed a covered stent in the distal aorta, which was post-dilated, and then placed 8x79 millimeter Violon VBX into each common iliac artery. And you can see on the picture there on the right, this creates a complete endovascular reconstruction of the aortic bifurcation, or CRAB configuration, stent grafting of the distal aorta and proximal common iliac artery. After this was done, there was IVUS was readvanced. There was no residual stenosis on the right, no residual stenosis on the left common iliac artery. The aortic stent also was widely patent and well approximated to the patient's more normal appearing mid-infrarenal aorta. IVUS was readvanced, and despite the severe stenosis and occlusion, pre-intervention, post-intervention, you can see that the patient had quite a good result. On the right, the IVUS demonstrated roughly 8 to 9 millimeter patent iliac artery stent, and on the left, the 9 to 9.2 millimeter common iliac artery stent, consistent with 0% residual stenosis bilaterally. So I measure success based technically at the end of the case. How did the case end up? Were there any hiccups or pitfalls? How were these managed? but I also measure success in terms of patient outcomes. And it's really reassuring and rewarding to see a patient who undergoes a complex intervention, particularly for disease as bad as hers was, who has a significant improvement in both ABI and in subjective measures like resolution of ischemic breast pain, resolution of intermittent claudication, and return to ADLs and quality of life measures.